So we just had a wonderful whirlwind of the essence of life, and now we're going to go into the more specifics of certain areas and prevention. And it is a pleasure to introduce Dr. Eric Ganguly, who is a gastroenterologist and is actually, I think, going to be able to tell us one of the best success stories so far in prevention, because a number of years ago, prostate cancer got the dubious distinction of moving ahead in badness, ahead of colorectal cancer, because colorectal cancer was doing so well in prevention and early detection. So I think this is a very important story to hear. Dr. Ganguly is integral part of the College of Medicine and UVM Medical Center, and it is a pleasure to welcome him. Data carriers.
Oh yeah, this is the new level of encryption.
We just recently upgraded with everything at the medical center to be like triply encrypted.
Is it a point?
You can see that it does work for me.
Right. All right. Well, thanks for having me. It's a pleasure to come and speak on something that at least I know a little bit about, so that's always comforting. So I'm going to talk mostly about colonoscopy, but I'm going to try to put that in the context of colon cancer and colon cancer screening. Something as gastroenterologists we spend a lot of our time and efforts on, and is probably one of the most rewarding parts of our job. So as Dr. Parapato said, colon cancer is common. So both in men and women, it's the third most common cancer, behind only prostate cancer and lung cancer. And it represents about 8% of all cancers annually diagnosed. There are risk factors for colon cancer, and there are things that that we can do to change our risk, and there are some things that just aren't modifiable. So age is a risk factor. As we get older, our risk for colon cancer increases. If you happen to have a personal history of colon cancer, your risk of getting another colon cancer is also increased. Your family history plays a role in your risk of colon cancer. That's mostly if you have first-degree relatives, so essentially parents or brothers or sisters who have colon cancer, you'll have an increased risk. If you happen to have multiple uncles or other second-degree relatives, that will give you a little bit more modest of an increased risk, and race has a role. So we just heard a talk, it sounds like, on diet. So diet does have an impact on our risk for colon cancer, and that is something that we can change. So diets that are high in fruits and vegetables, low in processed foods and meats are preferred. And physical activity is protective against colon cancer. The three things of obesity, smoking, and alcohol use, you could probably put that up for most cancers, but those are risk factors for colon cancer as well. So those are things that we can impact on for our risk. A little bit about survival in colon cancer, and this is an important tenet for most cancers. On the left, or on my left, your left too, is the stage of cancer. So it goes through stage 1 through stage 4. That's how we stage most cancers. That depends on the size of the cancer and how spread it may be throughout the body and lymph nodes. But a general principle of all cancer is that earlier stages are much more likely to be cured and associated with better survival. Unfortunately, if you wait to have symptoms to have your cancer diagnosed, it tends to be diagnosed at a higher stage. And that's where the whole concept of screening comes in. So if you look at stage 1 cancer, which is a very early cancer, it's superficial, it hasn't spread anywhere, 5-year survival is better than 90%. If you wait until you have a stage 3 cancer, which is when we start to think about people becoming symptomatic, that 5-year survival could be less than 50%. So that's a huge difference. And that's why it's so important not to wait until you have symptoms to look for cancers. And that's why we recommend screening so strongly, because that's where we can make our impact. So where does colon cancer come from? How does it form? Really, colon cancer comes from polyps. And what polyps are they're abnormal growths of tissue. So, in this slide, the pink represents the lining of our colon. So that's called the mucosa. That's the normal cells that line our colon. And based on your genetics and some of the environmental factors that we talked about and those risk factors, some of the cells in our colon can start to grow abnormally, and they can start to form polyps. So these are little bumps of abnormal growth that start in the colon. And many of these polyps start out as benign polyps. So they grow, and then the cells within these polyps start to accumulate other changes. And as the genetics of the polyp become more scrambled up, they can basically start to grow uncontrollably. And that's sort of this white part of the polyp here, where we start to get cells that have lost their control or their brakes on their growth. And then they can become a cancer that can invade. So we start out as polyps, and eventually, in a subset of those polyps, we end up with a colon cancer. And this is a picture from a colonoscopy of what a polyp looks like. This is a very classic, what we call a pedunculated polyp. It's growing on this stalk out of the wall of this normal lining, our mucosa of the colon. And this is a growth of the polyp. This isn't yet a cancer, but this is a polyp that could have a risk to become a cancer as it grows in size and as it accumulates its genetic changes. So when we're doing colonoscopy, these are the things that we're looking for. We're looking for these abnormal polyps and removing them to reduce people's risk for colon cancer. And that was a really nice introduction because, screening for colon cancer is a success story. It used to be that we could get up here and say we think we're doing a good job, and now we can really show that we're making an impact. So this cartoon shows trends for different cancers based on the most recent cancer statistics that are published yearly. And this top line is prostate cancer. So, prostate cancer is decreasing. Some of that may be that we don't look for it as much as we did at one point, but lung cancer is decreasing, and that's because people aren't smoking as much. But if you look, colon cancer is also decreasing. This is a nice slope line going down. And I'd like to say it's because people are eating better and exercising more and aren't as obese as they used to be, but we know none of that is true. The reason why colon cancer is decreasing is because we can screen for it. And because we can screen for it and we're doing so, we can reduce people's risk for cancer. So that's a success story. So I'm going to spend a little bit of time talking about how we screen for colon cancer, what the options are, and specifically talk about colonoscopy and the procedure and try to maybe debunk some of the fears or myths that are associated with it. So what makes a cancer or a disease a good target for screening? We talked a little bit about it. So, first of all, it should have a significant impact on public health. It doesn't make sense to screen for something that's a 1 in a million shot because those efforts won't really bear any fruit. So colon cancer certainly fits that bill. It's the 3rd most common cancer. We talked about that. And then importantly, it needs to have a period where it's asymptomatic, where you can make some kind of impact and detection. And that's where those polyps come in. So fortunately, colon cancer just doesn't start and turn into a cancer overnight. There's this period of time that takes many years for a polyp to develop and then a polyp to degenerate into a cancer. So that gives us a window where we can screen for these polyps and remove them and make an impact. And of course, the outcomes have to be improved during this asymptomatic period by our interventions. And that's what that last slide has just showed. By detecting and removing polyps, we can reduce the incidence of colon cancer. And then there are features of the test that need to be important as well. It has to be sensitive, so we need to be able to find polyps. It needs to be specific, so when we do the test, we can't go in and say that these other things are polyps when they're really not, so we're putting people through tests that aren't helpful, and it needs to be acceptable to patients. And our tests for colon cancer screening are uniformly acceptable, although sometimes people do have some fears and concerns about them. So the American Cancer Society has guidelines for screening for colon cancer, and they basically break them down into tests that either detect cancer alone or detect cancer and precancerous polyps. So it's important to know, though, that no matter what screening test you have looking for colon cancer, if your results are positive, ultimately it's recommended that you have a colonoscopy, because the protection against developing colon cancer really comes from the detection and removal of polyps. And to remove the polyps, you actually need to have a procedure to go in and find them and to remove them. It doesn't mean that these other tests aren't good. It just means that if you have a positive result, your doctor is going to recommend that you have a colonoscopy. So even if you choose something, quote, less invasive, you need to know that ultimately if you have a positive test, you'll end up with a colonoscopy. So that's what the recommendations are. And then these are tests that aren't colonoscopy that are options for colon cancer screening. So on the top, there's flexible sigmoidoscopy, which is similar to a colonoscopy. It just goes through less of the colon. There is something called a double contrast barium enema. This is a radiology test where they put contrast and air into the colon and take X-ray pictures looking for polyps that way. And there's a CT version of that called a CT colonography, or a virtual colonoscopy, where they do a CAT scan or a CT scan of the colon and look for polyps. So those are tests that can detect polyps and cancers. There are also other tests that look mainly for cancer and try to find it early where we can impact on it. And those are the tests that are less invasive and done mostly on our stool. So you can go into the office and the doctor can send you home with what are called stool cards. These are basically chemical tests where you look for the stool and you look for the presence of blood in the stool as a marker that there may be an abnormal growth in your colon. And if those tests are positive, you would go on to have a colonoscopy to investigate. And then most recently, there has been a test that is designed not to look for blood in the stool, but to actually look for DNA and look for these DNA changes in the stool that represent cancers. And that's the newest screening test. Again, that's done on stool, so it's non-invasive. If any of those tests are positive, then you would go on to have a colonoscopy to see where those positive tests came from. And if it's from polyps, we would remove them. If it was from a cancer, we would diagnose it, and then you would have that treated. Just a little bit about family history. Your family history really impacts mostly the age when you would recommend to be screened. So the American Cancer Society and other GI and medicine societies recommend that an average risk person start screening for colon cancer at age 50. If you do have a family history, especially if you have a family history of someone who has cancer, what we call earlier in age, so that's before the age of 60, then we would recommend that instead of at 50, you would start screening for colon cancer at age 40. So if you happen to know that your mother or father had colon cancer before the age of 60, you don't want to wait till you're 50 to start your screening. You let your doctor know, and they would recommend that you start earlier. If you have a family history of colon cancer and someone who's older than 60, it's somewhat controversial. The American Cancer Society still recommends starting earlier, and if that's normal, you can go back into sort of the normal pool of screening. And then how are we doing at screening? So in Vermont, I think we do take some pride that we do rate amongst the top 10 of states in the country for citizens who are undergoing cancer screening for colon cancer. This doesn't include just colonoscopy. This is any type of colon cancer screening. So this is based on this BR FSS survey that's done every few years. And if you look, the rates for cancer screening, about 70% of people in the state of Vermont who are polled by this survey have had some type of cancer screening in the last 5 years who are age appropriate. But interestingly, this falls behind some other screening in other populations that people could argue are less effective. So for instance, if you look at the data for mammography for breast cancer, that's closer to 80 or 85% of women who are appropriate have had a mammography. And many people would argue that screening for colon cancer is more effective than screening for breast cancer. So there's always room for improvement. And we do target rates higher than that. And we work together with the American Cancer Society and the Vermont Cancer Society to try to increase our rates for screening. So just in summary, and some take-home points, the bottom line is that any test is better than no test. You don't have to have a colonoscopy to have screening for colon cancer. Some of us think that may be the preferred test and maybe the most efficient, but other tests are available. If you do have a family history of colon cancer, that may trigger that you be screened or consider screening at an earlier age. And just remember that the benefit from colorectal cancer screening of any kind really comes from the detection and removal of polyps with colonoscopy. So I want to talk a little bit about the procedure itself. Maybe prevent you from having to be dragged to your procedure if you choose to have one. So here's a picture of what a colonoscope looks like. So this is it on the right. It's a long, very flexible rubber tube that can be steered through the colon by an operator. Very common procedure. And this is a nice close-up of what the tip of the instrument looks like. There's a little channel that allows us to pass instruments down, and that allows us to remove polyps. There's an incredibly bright camera and an amazing lens that allows us to get high-definition pictures of the lining of the colon, and a little place where we can squirt water in. And this is done in a procedure room with a patient sedated and comfortable, and the scope is steered through the colon, and then the colon is very carefully inspected as we withdraw the scope, looking for anything that's abnormal and removing polyps, and that's how we do the procedure. And this is sort of a cartoon of how our colon lays in the body. So, this is the pelvis here, and the upper and lower abdomen, and we basically steer the colonoscope up through the colon and then withdraw it back, looking for polyps. So if you decide to have a colonoscopy, this is really the sequence of events that would happen. You'd go and talk to your doctor about cancer screening. They would potentially recommend that you have a colonoscopy, and you would start off with just scheduling the procedure. So you put it on the calendar, and you pick a date to do the procedure. And then someone's going to send you something called the prep. And there's no way getting around it. This, for most people, is the most uncomfortable part of the procedure, but without cleaning out the colon, we just can't find polyps or see them. And I've got some pictures to demonstrate that. So the prep involves taking a substance that basically flushes you out and causes you to have diarrhea for a couple of days to clean out the colon. This is a picture of a brand called Go Lightly. Basically what it is a drink of, yeah, very aptly named. It's an inert substance that basically draws some extra water and flushes the colon out. So you drink it, you split it over a couple of days. We put you on a clear liquid diet to help the prep for the day before the procedure. And then everything is cleared out, and you come to the endoscopy area, and you check in. The nurse will put an IV in you, and then you'll meet your doctor, and you come in, and we'll give you some sedation, and then we'll start the procedure. So patients are sedated with what's called conscious sedation. You don't have to be under general anesthesia under most circumstances. People are given a benzodiazepine or something like Valium together with a painkiller or a narcotic in low doses. Incrementally, we give each person just what they need to sort of survive the procedure, be comfortable. And then we go in, and if any polyps are there, we remove them. Otherwise, we inspect the colon, and you go out to the recovery area, and you wake up, and then your doctor will send you a letter saying, I found some polyps. Here's when I recommend you come back for a procedure. Or we didn't find any polyps. You can come back in 10 years. And then that goes into our system, and you'll get a reminder for your follow-up procedure. So is this a safe procedure? The bottom line, colonoscopy is a very safe procedure. There are risks of any procedure, but the serious complication rate for colonoscopy is about 2 in 1,000. And that may be an overestimation of the risk in modern days. So the risk of a perforation, meaning putting a hole in the colon, something that would require a surgery or something very significant, varies from either 1 in 1,000 to 1 in 10,000 procedures. So somewhere in the middle, that's a very low risk. There is a risk of bleeding if we remove polyps, and maybe about 1 or 2%. Most of those can be managed without any further follow-up. Once in a while, you'll have to go back in with another procedure to stop the bleeding. The risk of any reactions to the sedation medicines that we give in the average person is very rare. So overall, the risk of the procedure is quite low. So it's a great procedure. It's effective. You know, what prevents people from having colonoscopy or colon cancer screening? And when people have looked, you know, there's 4 reasons that are the most common for people saying they didn't have a colonoscopy. One is, you know, people are afraid of discomfort. It doesn't sound like something that you would sign up for, you know, if given the choice sitting on the day. And I understand that. I think everybody understands that. You know, lots of procedures, you know, sound uncomfortable, and that can create fear. You know, it's embarrassing. There are a lot of things in medicine. You know, women come in and have pelvic exams. You know, you get a rectal exam in the office. You know, these are things you can't get around, but we try to, you know, get people over their embarrassment. These are things that we do every day. People are very professional. You know, for us, there's nothing embarrassing, and our job is to try to make sure that our patients don't feel embarrassed and try to manage that and be aware of that. You know, unfortunately, a common reason for people not getting colon cancer screening is that it's not being recommended. And that's our job to help as gastroenterologists and specialists to educate our colleagues and the public of the importance of screening, and I think we're doing a good job at that. And as I said, a lot of people have heard horror stories about the bowel prep, and you know, we try to get people through that. But just an important fact I want to tell you is that when I was a fellow, I worked with Dr. Zubarik, and we did some studies. We were comparing patients who had flexible sigmoidoscopies and colonoscopies and doing some research. And one of the questions that we asked after people's procedures was, would they be willing to have a colonoscopy again? And we surveyed 225 people consecutively, and all 225 people after they had their procedure said they'd be willing to undergo another colonoscopy. So, you know, the most common comment I get when I tell people the procedure is over is they kind of wake up out of twilight and tell me, that's it? You know, I was so worried about this, I can't believe it. So, you know, it really, 95%, 99% of the time is a very comfortable procedure that doesn't cause a lot of pain or discomfort for people. So a few things that are new or that you may have heard of in the news. I'm going to go over these before I take some questions at the end. Just things I want to make people aware of if you've heard about them. One is this information that came out last year in JAMA that talked about colon cancer in people under the age of 50. So interestingly, we've been seeing more colon cancers in people who are younger, people in their 30s and 40s. And this is a projection over the next 20 years or so of a 90% increase in colon cancers in patients who are under the age of 50. You know, that's an interesting fact. So we don't know what's driving this. This may be some combination of genetics and our environment. But one thing I want to make people aware of is this is an incredibly small percentage of the overall risk for colon cancer and colon cancers. So even though the percent increase in this patient population is significant, it's still starting out at a very low level and increasing by a small amount. But it's something that we're keeping an eye on. People are studying this, and you know, ultimately, if this trend increases, it may influence, you know, some of our policies on when we recommend screening for colon cancer to start. And this trend has been especially more common in cancers that are involving the rectum and the colon. So there may be alternatives to colonoscopy for looking at this patient population. Again, this is a very small percentage of colon cancers that are out there. You may have also heard that colonoscopy isn't as good at finding cancers that are in what's called the right side of the colon. So that's that part of the colon that's all the way at the end where the cecum is, or up and around. If you're thinking of your body, that's on sort of the right side of your abdomen. And one of the clues is that there are these other type of polyps that we've become familiar with finding over the last 5 to 10 years that are these called sessile serrated polyps. This is a picture of what they look like on the right. They're not that big kind of cherry-looking polyp that I showed you before. These are very flat, fleshy-looking kind of subtle lesions. They have a distinct pathway to cancer from those other pedunculated polyps genetically. They're often on the right side, and they may account for about 20 or 30% of cancers. They can be difficult to detect, and this is where taking the bowel prep and doing a good job at cleaning out is critically important. One thing we've done as gastroenterologists is educate ourselves on how to detect these lesions and how to find them. So we're doing a better job at that, and I think people have been able to show that there is protection of colonoscopy in the right side of the colon. And we may find that that protection increases as people's awareness of these types of polyps and their skill at finding and removing them increases over time as well. So, here's just an example of what a good prep looks like and what a bad prep looks like, and why it's so important to do a good bowel prep. So this is one of those sessile polyps that's on the left in a good prep, and you can see that if you had this prep, you're never going to find this polyp. So you're not going to get the protection. So we spent a lot of time figuring out how's the best way to prep for a colonoscopy, and the most important thing you can do is to what we call split the prep. So you take half of that liquid Go Lightly or whatever we prescribe the day before the procedure, and then you take half of it the day of the procedure, and your last dose done within about 5 hours of the procedure. And that's been shown time and time again to give the best prep. And this is just a slide that shows that this has been studied many, many times, and anything to the right side of this line says that the split dose is better. So there's no debate. That's the best way to do it. If you hear anything else, that's wrong. Tell your doctor that you want to split the prep. And then the most recent screening I talked about before is the fecal DNA. What this does is this is a kit that you can actually do at home and mail in, and it looks for DNA changes in the stool that would be shed by cancers or polyps. Using modern genetic testing, looks for these changes and gives you a result that's positive or negative. And it's a very good test. So this says 92% sensitivity. It's a very good test for detecting cancers. But if you look at precancerous lesions, the sensitivity is about 42%. So it's not as good of a test for finding precancerous polyps. It's new. It's certainly something that can be used, and it's recommended by the American Cancer Society. I think its ultimate role in colon cancer screening is still being defined as far as how often you need to have the test and what kind of protection it provides. Again, if you have a positive test, your next step would be to have a colonoscopy. And then lastly, something that's been in the news a lot recently that I wanted to address in case anyone has heard about it is these infections that have been related to endoscopes. You may or may not have heard about this, but there's been several centers in this country that have had these type of bacterial infections that they believe are related to certain types of endoscopes. And these are bacteria that have a lot of resistance to antibiotics and are very difficult to treat or get rid of and can be associated with deaths in certain cases. Fortunately, these are really limited to special scopes that we use to do specific procedures called ERCP or endoscopic ultrasound. These type of scopes have this elevator device that really help us get instruments up into the bile duct. And it has to do with tissue being difficult to clean from these elevators. And they're resistant to common antibiotics. and they're called these CRE-resistant Enterobacter species. We've looked here at the University of Vermont. We've had no endoscope-related infections. And all of the risk from these endoscope-related infections is limited to the specific devices used for these other procedures. So there's no risk of infection from these type of bacteria associated with colonoscopy or colonoscopes. So the bottom line is that colonoscopy is safe, and then you don't have to worry about getting an infection or one of these infections from having your procedure. So I think I'd like to save some time for questions, and that's all I have. Yes?
At what age do you give up colonoscopy?
That's a great question, and I probably should have included that. So that is controversial. Oh, I'm sorry. Yeah, so he asked, at what age do we stop screening for colon cancer? So assuming that you've been getting screening, when can you throw in the towel and say enough is enough? Some people say that we can stop screening at age 75. Most of us individualize that for people. So if you've got other health problems and you're not as likely to benefit from screening, then certainly that makes sense. You know, we all see people who are 75 who are very healthy and fit and going to live another 15 or 20 years. Those patients certainly can still benefit from colon cancer screening, because the reality is that the risk for colon cancer continues to increase as you age. So we weigh the risk and benefit of, you know, having an invasive procedure, going through the test with, you know, what's your likelihood of benefiting from the screening, you know, with ongoing survival. Yes, sir.
Well, I've had 2 colonoscopies, and they seem quite simple. But when I got the bill, I was shocked. $5,000. Why is it so expensive?
Well, you know, that's a complicated question, but it is expensive. You know, fortunately, it's covered by insurance for the most part, but, you know, the cost involves with coming to the hospital, you know, having the procedure, having it in a specialized facility, you know, providing the expertise for the sedation, the procedure itself, the pathology. So there are a lot of costs that that mount up, and you know, that's you know, just something that, you know, we as physicians can't really avoid. You know, we try to keep the costs as under control as we can, and you know, that's sort of a national health issue as well. Yes, sir.
Is it more difficult to remove sessile polyps?
It is more difficult to remove because they're flat. They're not as easy to kind of snip off, but we have ways of lifting that polyp up off the wall of the colon where they can be safely removed. There is a bit more risk of leaving some polyp behind when you have a flat polyp like that. So I would say technically it is more challenging to remove those lesions, but something that there's been a lot of focus on as far as education and training of people on how to detect and how to best remove these lesions.
How long does it take for a polyp to develop into a cancerous polyp?
So that's a great question, and you know, that's probably a moving target as well, but historically it's been felt to take about 10 years. So there have been a lot of older studies on the polyp to cancer sequence that says it takes about 10 years for a polyp to then go on and develop into a cancer if it's going to. So that's why if you have a colonoscopy and you don't have any polyps, it would be recommended that you have another procedure in about 10 years.
If a polyp is removed, how likely is it that another one would develop in the same place? Does the scar tissue or the reason it started there in that location have anything to do with whether it might come back?
It really depends on how it was removed and whether it was completely removed. So a polyp that's completely removed has a very low likelihood of coming back in that same place. The only way a polyp would come back in the same place where it was removed is if you left some microscopic polyp tissue there that you didn't know that was behind that can then continue to grow and come back into another polyp. Yes, sir. Yep, you.
Demographics. I saw that there was one scale that spoke to Hispanics, white Hispanics, non-white. I don't fit those. So what's the best focus for me to get some feel for how this affects me?
As an African American?
Absolutely.
Yeah, so the risk for colon cancer is increased in African Americans compared to Caucasians. I don't have the specific data or as far as the risk, but there has been some suggestions of starting colon cancer screening earlier in African Americans at age 40. That has not yet reached the society levels where that's been recommended, but there has been some discussion and debate about that. Anyone else? Do you have a question? Yes.
I guess I do. Observation first is that I had the serial type and had ulcerative colitis for 10 years prior to that. And sort of as a result of that, a decision was made and a second opinion to take my whole colon rather than just deal with the stage 3 and 3 serial serrated. So that was during a time when, just after I lost my pancreas and cancer, that my colitis went dormant. And the doctors chose to believe that that meant nothing was wrong. And it stretched my colonoscopy frequency out longer than probably was appropriate. But at any rate, I certainly would bear the colonoscopy gladly compared to my situation today.
Yeah, well, thanks for that comment. One thing I didn't mention, talking today about screening, so we're talking about, when you're talking about colon cancer screening, we're really talking about average risk in asymptomatic patients. So I didn't spend any time talking about specific high-risk groups, which would include, patients who have certain polyp syndromes, patients who have inflammatory bowel disease like ulcerative colitis. That's a specialized group that has their own recommendations that are completely separate from the general population, but thank you.
And my question after that, as far as identifying high likelihood cases, it seems like several offices have gone into doctors' offices and others have had posters up saying that if you are leading a dormant lifestyle, if you're an office worker, and that demographic, you're much more highly susceptible to colon cancer than ever thought before. So are they being identified now as an early diagnostic group?
No, not separate from the general population. So, exercise and diet and other things are protective, and the opposite of that is a risk. But there are a lot of people who have desk jobs and have a sedentary lifestyle. Those people still benefit from average risk screening at age 50. Maybe one more question, sir.
Do you find any association of polyps in the colon with conditions elsewhere in the GI tract?
There can be in specific cases. So there are genetic syndromes that can lead to polyps in the colon as well as polyps outside the colon, so in the stomach or in the other part of the small intestine. There are some other genetic cancer syndromes that involve colon cancer and cancers in other sites. But these are very specific, genetic risks or diseases or polyp syndromes that are usually identified by a patient's family history. So these are almost always people who have a strong family history of not only colon cancer, but cancers in other parts of the body as well. So that's where giving your family history to your doctor and allowing them to interpret that as far as your overall risk for cancers or other things comes into play. Well, thank you very much.
You're welcome. Yes, and thank you to everyone. And now we have made it to a wonderful 15-minute break time. And then we're going to have breakout sessions and information on the breakout sessions if you need it. We'll get right outside at the desk. And then after the breakout sessions, we will reconvene right here at 11 o'clock to do a couple more Boyd topics on prostate and testicular issues. Thank you very much.